So this wonderful program was built by Ingrid by Kymora. So please, Kymora, join us. You are the co-chair of this session, and it's a wonderful session. And Kymora was the responsible. So please join us. And Dr. Kymora Scotland from UCLA. Please. I think that. Yeah, yeah.
Okay, thank you, Pablo. So, for this session, we are going to be talking some more about kidney stones. We're going to have a couple of updates on the new kidney stone AUA, new kidney stone guidelines for surgical management of stones. And then we're going to have some really fun sessions because we're going to be having some debates back and forth. And then we'll end with a question that I think is in all of our minds. What's going to happen to the surgeon? Okay, so I think the first one will be me. So I will move over. And again, I just want to take the opportunity to thank Ingrid for the invitation. It's been really lovely working here with all the colleagues and learning. And while learning, educating others. Okay, so kidney stone surgical guidelines. And this is a more practical discussion. So, what I want to do is, and these are my disclosures, which I've mentioned before. An additional one is that I am one of the members of the AUA Kidney Stones Guideline Panel. However, I do not speak for the AUA, and so these are my thoughts on what the guidelines mean. So, we need evidence based information to determine how we should manage our patient stones. And that is the whole reason for these guidelines because we've been treating stones for a long, long time. But, why we do certain things is not always clear. So, what the guidelines do is they follow the management of kidney stones from the pre-operative setting before we decide what we're doing with the patient, all the way through surgery, and then post-operatively how we should manage those patients. And so, the things we're going to be talking about are imaging and preoperative care, the different types of surgeries that we typically will use nowadays for kidney stones. So, those are shockwave lithotripsy, also known as ESWAL, which is what I tell patients is the least invasive thing that we do. We don't go into the patient typically for shockwave. We use a probe to break the stones from outside the patient. And then there's ureteroscopy or retrograde intrarenal surgery where we go in with a scope to break the stones. And then finally, percutaneous nephrolithotomy or PCNL, where, as you saw Dr. Juicy just show, we go in through the back to treat the patient. Okay. Now, for the guidelines, we determine whether a statement that we make is a strongly evidence statement or something that we really stand behind based on the quality of the evidence that led to that statement. So we look at the literature, and then based on the literature, we determine whether it is a high quality statement backed by, typically randomized controlled trials or versus a lower quality statement where there's not a lot of evidence. And then we make recommendations based on that. And those recommendations can be either strong recommendations, which we think really should be followed, all the way down to conditional recommendations where we think there are multiple options, and then expert statements where there's not really any data to support it, but we as a panel agreed that this was probably something people should be doing. And so then the last statements were written in 2016. So we're going to compare the changes that were made in this new statement as compared to 2016. And then at the end, we'll talk about the differences with the European Association of Urology statements as well. These are both systematic reviews. And as I said, all the studies having to do with kidney stone surgery from 2000 to 2025 were evaluated for this most recent guideline. And then we came up with about 60 recommendations. Okay, so preoperative evaluation, the differences. So, what I'm going to do is just talk about the differences. As you can see, we have a lot of statements, and really, there, I would say the overwhelming majority of statements in the new version really are quite similar to the 2016 version. And the reason for that is because there's not that much data in kidney stone surgery. And there are some things that, are widely agreed upon and nobody's going to really do a new study on. So things like, how do you take care of patients, making sure that you get labs, all of these things. These are things that we all agree on. Okay, so for preoperative evaluation, there are some slight changes here. In 2016, obviously, everybody agreed that you should really get a CT scan before a PCNL. You should get a urine culture, and some sort of functional imaging as needed for the different procedures. Now in 2026, we agree that you also need a CT before PCNL and a urinalysis or urine culture, but there is an enhanced risk on assessment focus. So we want to look at procedural risk assessment, comorbidities, and differential renal function as we decide what procedure makes the most sense. And then we wanted to make a statement about UTIs or pyuria really precluding surgery, that those things should be treated first before taking a patient to surgery. And that's not something that we had mentioned in the previous guidelines. And then I want to talk briefly about this idea that we should specifically do a CT scan before PCNL. So the question would be, why didn't we talk about ESWAL or ureteroscopy? What kind of imaging do we need there? There's not really a lot of data to support doing CT versus, ultrasound versus an X-ray. And your question would be, well, why? Nobody's done these studies. Okay, so we have left it to the surgeon to decide what imaging you would like to do for shockwave and for ureteroscopy, but for absolutely for PCNL, you should have a CT scan. Okay, so medical expulsive therapy. When a patient presents with a stone, especially if they present with a small kidney stone that is obstructing the ureter, we may not necessarily need to take them to the operating room. We may discuss with them the chance that they can pass the stone, and so we will give them medications to help them to do that. So in 2016, the statement was that alpha blockers should be prescribed for distal stones less than 10 millimeters, and we do say that as well in 2026, but we give a time frame. And so we say for approximately 30 days. And then we've also expanded that to include proximal and mid-ureteral stones. The recommendation is a strong recommendation for distal stones, less so for the proximal and mid-ureteral stones. There's not really that much data. But on the whole, it appeared that alpha blockers would help passage. All right, so for ureteral stones and the management of ureteral stones, people might be surprised by this, so I wanted to take a little bit of time to talk about it. I think we all know that ureteroscopy has a better stone-free rate than shockwave lithotripsy. And so we're not saying that that is not the case here, but we wanted to have some nuance because lots of people do still use shockwave lithotripsy and lots of patients do still appreciate shockwave lithotripsy. So the point that we're trying to make here is that for distal stones less than or equal to 10 millimeters, you can do either. And then for proximal stones less than 2 centimeters, you can also do either. With the understanding that stone free rate is better with ureteroscopy. And so we really focus on shared decision making with the patient. But we really wanted to make sure that we codify this notion that people should not be doing multiple shockwave lithotripsy procedures. So no more than 2 shockwave procedures. If it doesn't work, move on to something else. And then if ureteroscopy or shockwave fails, you should move on to a percutaneous approach. So kidney stone management. Um, we also recommend PCNL for large stones, but there are now more data supporting size ranges. So really for any stone, particularly in the lower pole greater than 1 millimeter, you should be considering a percutaneous approach. There's very strong evidence to support that. Um, Obviously, I don't think anybody's putting a 30 French sheath in for a 1.2 centimeter lower pole stone. Mini PCNL is an option here. If available, suction sheaths are recommended. And we understand that not everywhere is the same. As Pablo mentioned, in Latin America, maybe a little bit different to North America. And we understand that not everybody's going to have access to suction sheaths. So we don't want to be very prescriptive with the guidelines. We're trying to give everybody some wiggle room. Suction sheaths, like I said, are available. You may omit a nephrostomy tube after PCNL, and both prone and supine positions are acceptable. We added this notion that for people who come in with painful, non obstructing stones, we should consider surgery. There are data now to show that these patients do better after their stones have been treated, even if they're not obstructed, even if the stones are small. And again, I mentioned mini PCNL, really up to 3 centimeters is recommended. Okay, so for shockwave and for patient centered care, a lot of the conversations around treating with shockwave really have to do with shared decision making. So in 2026, we're starting with this notion that we recommend a low energy start. Okay, so low energy settings to start with to decrease bleeding risk. And there are some data now to support that. Um, and then this slow shockwave strategy will optimize stone clearance and it should minimize complications. And there are some data to support that, but it's grade C. So again, grade C, lower quality studies. Okay. And then in the last few minutes that I have, some miscellaneous recommendations that I just wanted to bring to people. So we did include a discussion of suction ureteral access sheaths. These are fairly new. We'll be talking about them a little bit later, but there are already some emerging data to support their use. There's emerging data to support the use of single-use ureteroscopes. We're not saying you cannot use reusable. We're saying that single-use ureteroscopes are an option. And then when you're talking about the different types of lasers, as we've discussed, really holmium versus thulium is dealer's choice. We do recommend at least discussing with patients the idea of going back to clear residual stones because there are data to show that when you leave residual stones, patients will have further episodes down the line. And then patient scan fragment versus dust. There are some data to show increased rates of stone free patients with fragmentation. However, again, the data is not A grade, and so we recommend both. And then finally, uh, we have an really what is an expert opinion that we should be making sure that we get urine culture specimens from the collecting system with obstructing stones. And we all felt strongly that this was something that we wanted to codify so that we decrease sepsis. Okay, so what about the EAU guidelines? And so, really for the EAU versus the AUA guidelines, I think the difference there is more of a selection based on stone size, composition. But with the AUA guidelines, we've really tried to stick to sizes as we determine what should be done. And so that's one way of thinking about it. So for imaging, we are recommending CT before PCNL. The EAU says that low dose CT is the gold standard, but are still considering ultrasound. Shockwave lithotripsy, we're talking about low energy settings. The EAU guidelines actually are fantastic with shockwave. There are detailed protocols by size, by composition, by location, which is very helpful. For ureteroscopy, again, we're talking about ureteroscopy or shockwave for distal stones, and then moving to ureteroscopy with failed shockwave. Really, the EAU guidelines recommend ureteroscopy, and that selection is based on stone size, composition, anatomy. PCNL, again, greater than 1 centimeter, especially in the lower pole, we recommend PCNL and mini PCNL within the kidney for stones that are less than or equal to 3 centimeters. The EAU guidelines recommend PCNL for complex or staghorn stones and combined PCNL and RIRS. Now, in the AUA guidelines, we did not specifically discuss ECIRS, but this is something that certainly has a similar outcomes compared to PCNL. And I think that, eventually is something that there will be lots of data where we will be able to craft a statement. Okay. And so just a way of thinking about the guidelines, as you read them, really thinking about the development of the guidelines, using a framework that we think allows us to really make strong statements where we can, and really pushing shared decision making with patients. Um, Preoperative evaluation, talking about UAs and cultures, and CTs before PCNLs, making sure that pyuria does preclude surgery. For MET, we recommend alpha blockers for both distal, mid, and proximal stones. And then for ureteral stone management, as I said, shockwave and ureteroscopy, with the understanding that, of course, ureteroscopy has higher stone free rates, and it's a decision with the patient. And then we talked about PCNL, we talked about how to manage shockwave lithotripsy, and just ending again, with the focus on patient centered care. We'll end here and happy to answer any questions.